First, I just want to say thank you to everybody and the organizers for this committee for having me today. It's pretty great experience to share from my perspective. So really, that's a great honor. So thank you very much. As Anna said, I am a nurse manager at St. Joe's, currently not nurse managing and managing all of those things, but I am still the manager for congregate setting COVID response, which will be the center of some of the things that I share with you today. It definitely has been a challenging year, but I'm pretty pleased to share some of the innovative and positive things that I've learned in the last year. So first, this is my declaration that I do work for St. Joe's and I don't have a conflict here today. Next is this is a bit of the background I want to share with everyone. So Partners in COVID supporting our congregate settings came about last year, just over a year ago. So this is a group that came together to support our congregate settings, pulling from a number of different community providers and really pulling us all together because I think we all recognized very early on that it was going to take a partnership and a team approach. So back in April 2020, St. Joe's partnered with Public Health, Hamilton Health Sciences, our LIN community care, long-term care homes, retirement home representatives, as well as RCA representatives, the city of Hamilton to really come together to a table to discuss the crisis at hand, as well as some of the directives moving forward. Since then, we've done a number of things together through the Partners of COVID table, as well as internally at St. Joe's to help support this. So through ongoing collaboration with this for our long-term care retirement homes internally at St. Joe's, over the past 6 months or more, the director, Jane Lonke, and myself and Joanne Dieger, I'll speak more to our team in a little bit, but we've pulled together twice monthly meetings with directors of care, administrators of all the long-term care homes, retirement homes, and RCFs, because it became pretty apparent early on, connecting with one team or one home at a time wasn't going to hit and share the same message as bringing everyone together to hear the same concerns they have or the same problem solving. So we bring those parties together twice a week. We're still doing it to talk about hot topics. So initially it was a lot of the ministry directives coming down. How do we support? Do we have enough people? What do we do, when, how, where, how, and all those types of things. So hot topics we did discuss was outbreak management, recovery of an outbreak, vaccine hesitancy and resistancy, screening, and all of those things have been lessons learned. And we've brought key people to these meetings like Zane Chagla, Dr. Hugh Boyd, Dr. Oliver, to share some of the inspirations they have from their homes and what they've worked with, but also how do we work together, learning from each home that has or has not been in a crisis. From there, I think it's just continuing to grow. And I think these homes are really learning from each other and how do we support each other in crisis times and COVID times, as well as just continuation. Another parallel to that we recognized really early was the physician support and the primary care support. So in collaboration with Dr. Ingram, Dr. Khalid, Dr. Oliver, and Dr. Boyd, we held weekly meetings with the primary care physicians and medical directors from long-term care homes, retirement homes, family practices to really talk about what does COVID care look like in the community? How do we support COVID care in the community, knowing that you can't send every patient to the hospital that has COVID. So what can we do to support mild, moderate, and severe COVID? And also what does that look like in terms of new medications that were happening, nursing practice pieces. So I was at the table just to help kind of identify what can we as nurses in long-term care home do? What does oxygen look like? How does the NLOT team assist? This was also something really powerful for, I think, the physicians hearing from each other in terms of if they are in a crisis, what does that actually look like? And what does your day entail? And how do you assess all these patients? This was a way to share with them about hand hygiene practices, how to put on PPE and don and doff properly, as well as we did have I'm going to call it a COVID line here at St. Joe's. So if one of the physicians in the community needed to call and had a question about a COVID case, they could call our internal medicine COVID doc to just kind of problem solve with that, as well as utilizing LTC cares. But really, again, it was just pulling everyone together, learning from experiences and sharing information and what was working, what wasn't working, and how do we best support those residents staying in the home, knowing that they don't want to come to hospital unless they really have to. So how do we support their care? Other things that we've done internally is hired a number of healthcare staff and non-healthcare staff to help in case there is a crisis. So if homes are in crisis, they definitely always need help and support in terms of screening for people coming in terms of hand hygiene audits, PPE audits, just some of the things that we don't think about because that's not in their day-to-day practice. So how do we support them doing that? We have hired and we have had to train staff here at St. Joe's on what does working in long-term care retirement home look like, because we have had to go into those homes. And I think every nurse that has gone into the home, you can't necessarily prepare them for a different setting that they never worked in, but they have come out so much better and so much greater, appreciating the difference that care is in the community. And I think that's a huge lesson learned. We're continuing to partner with these homes on an ongoing basis and continuing to learn and grow and support them as the needs are. This is just a little, it's definitely not everybody, but this is kind of shares who the congregate setting team here. So the main congregate setting team here at St. Joe's is Cheryl Williams as the executive lead, Jane Lonke as the director, myself, Helen Harris, and Catherine Duffin as the management leads. We have Joanne Dieger as our IPAC lead, has been to every home with me, or even more homes with me, as well as Ann Bielikowski. We have environmental service leads as well to help support some of the questions in terms of cleaning and getting supplies. So that's David Keene and Clyde Coventry. And since some of the homes that we've had to work in, we've hired 2 RPNs to be clinical leads that have come to support these homes with me, and that is Mandy Lee and Megan McClellan. Other key people from public health are the COVID-19 management group, the infection control leads, manager of outbreak as the physician, and then home community care, as you know, is just as important in the community and even more so in terms of getting agency staff and supports to help during the crisis, as human resources is very difficult. So Kathy Brown is our lead for that. And 3 very important people that I think have been toe-to-toe with me in every home that has had a crisis is Dr. Doug Oliver, Tammy Packer, and Hugh Boyd, very helpful. And then our ministry partners for long-term care and retirement homes. This is just a picture to show kind of who and what the homes are that are associated with St. Joe's. We did split it up 60-40. So Hamilton Health Sciences has 60% of the home and St. Joe's has 40%. That being said, it does show that we added on Shalom in December as HHS was going through a very difficult time at Grace Phyllis. So St. Joe's helped and picked up Shalom. So this just shows where they are across the general area of Hamilton. These are the RCFs that we work with, again, across the Hamilton area. And this is what I will, in terms of talking to partnerships, so Joanne Jaeger, the IPAC lead, as well as myself, go on IPAC audits with our public health partners. What we do on these audits are preventative as well as during an outbreak. So we look for things on how to support them initially to make sure that they are following ministry standards, general IPAC standards, as well as in an outbreak. How do we get there within the first 24 hours to really make sure that they have the supplies they need, they have the education they need, and the support? Because when an outbreak is called, it goes hairy scary pretty quickly, especially when they don't have the supports that they feel. So building this partnership with them and being able to go on site before there's an outbreak, so they know our faces, they know our names, they know that we are there to support them and help them, I think has been one of the greatest things that we've done in the last year. So when we do go on site with our public health partners, we follow their IPAC auditing tool, but Joanne and I also look at other things in terms of care delivery, which is inclusive at the bottom. So we look at how many residents do they have, how many staff do they have, if they've had an outbreak, if they've not, what were the symptoms, because we do know that some of the symptoms are very different and some of them are not, they don't poke out like anything would. So sometimes they are a surprise to them. We look at their screening processes. So are they screening residents correctly? Are they screening their staff correctly? Do they ask the right questions? Are they taking temperatures? We look at all of their signage because we do want to support mask wearing. We do want to support social distancing. So we really kind of go in there in a fine-tooth comb to identify our staff eating together, our patients really sitting together, and kind of bringing that to our attention, because I think when you invite someone into these homes, they look at it through a different lens. We all recognize that RCFs, retirement homes, are not long-term care, but how can we support them within the confines of the care and the area and the environment that they have? We talk to them about PPE amounts and usage, because it's pretty, I don't want to say amazing, but it is amazing how much PPE you can go through if a home is an outbreak. And that is a lot for someone who's never really used PPE like a retirement home or an RCF. If you've never used a gown or had to order a gown, it's pretty miraculous to say you're going to go through 50 in an hour if you have multiple cases. So we talk through that with them. Joanne, as I keep highlighting Joanne, but Joanne's been a huge success and has probably been to every home and every RCF, if not at least once, but twice. And I think this has been a huge success, whether they go into an outbreak or not. Having us on the ground, going through how to properly do your hand hygiene, how to put PPE on, how to take it off, and the reasons for why and how to clean it. This isn't a structure or a support that is always there in the community. So providing this to them, and then also having a phone number to call or an email to touch base with us. We're still getting emails from homes a year later that aren't necessarily about COVID, but about IPAC practices and asking for advice, which I think is a huge success because of the fact that they don't always have these supports in place. So the fact that we've built this and built this partnership to support them shows how great I think it is. We review, as I said, we review environmental service products. So COVID, if we have in the hospital certain supplies, we don't expect the homes to have those supplies, but we do advocate for items that are contact time less than 3 minutes. When you're looking to support cleanliness of an environment and you only have 2 staff, it needs to be quick, it needs to be easy, but it needs to definitely do the job. So we bring in David Keene on site so that he can talk with their housekeeping manager to identify if they don't have the supplies, how can we get them the supplies? What supplies are they really using? Could they decrease some of the supplies? Again, it's different standards in long-term care home, retirement homes, and RCFs, but we don't expect them to be a hospital, but we do want to support them so that it's as easy as can be for them and they know how to get what they need. We also review practices, as I shared. So meal delivery, medication delivery, doing vital signs every time that you have a COVID positive or a COVID suspect. You need to change the way that you work. And if they have 20 patients for 2 PSWs, that's very different than here on an acute unit where you have maybe 2 patients for 1 nurse or 3 patients. So we talk through with them to go from clean to suspect to dirty. And all of this is new learning for everyone. So having the ability to be welcomed into their home is a huge success. And I think it really builds on, we're here with you, we're walking your steps with you, and we want to be here to support you. Next is just some key words from the last year. And I think I've said partnership, I don't know, maybe 12 times already. So I guess you guys are figuring out that that's one of the biggest pieces for the year. But the partnerships that we've made have been huge and they're priceless. So knowing that we're there to call, but I wouldn't say just the partnerships with the home and us. I think working with public health, working with Dr. Packer, Dr. Boyd, Dr. Oliver, having someone to call. We've all had to learn how to work differently, and we've all had to learn to ask questions or look at a situation. So having these people that we are part of the same team, looking at it and supporting our community in the best way possible has been a huge success. And I would hate to lose that. And I'm hoping and hopeful for continuing to bridge that with the Hamilton Health teams and moving forward with our community partners, because I think I have as much to learn from them sitting here in the hospital as they do from me, and vice versa. Some of the really exciting partnerships I think we did is, when St. Joe's went into Shalom, there was so much learning in terms of acute care service providers going into a long-term care home and learning to work differently. And working with the physician group and working with the LIN. But I think some other key ones were Victoria Manor, which is an RCF, and St. Elizabeth's retirement home. Doug Oliver and the LIN all pulled together. We got physician assessments in these homes because they don't have physicians on site in RCFs and retirement homes. So how could we support a COVID outbreak, getting patients medically assessed, the care that they need, the support that they need, without sending them to a hospital. So I think pulling all together, looking at what our resources are, who are key people were at the table, and really pulling on those people and asking, how do we instead of we can't, was a huge success to support those residents. And we're not going to stop, and we know we were not going to stop a lot of outbreaks, but what we can do is once an outbreak happens is keep it on a manageable level so that the staff feel safe, the residents feel safe, and we know that they're getting the care that they need. Education, I think, as I've also preached about, has been a huge success in just being able to go out there, to stand with the staff, to ask their questions, to provide the answers and the rationale and compatibility. So all those three words together make sense, because once we were learning, and I think Joanne and I understood, once we were talking about COVID, it became a little apparent that we need to talk about how COVID is transmitted. If someone doesn't know how it's transmitted or the risks around it, they're not going to appreciate that they have to wear a mask and a shield and a gown and a glove. So what does it mean, transmission, and how does it transmit? And we needed to look at their home differently. As I said, working on a 30-bed unit, having multiple staff, housekeepers, allied health here to support and help us get things, versus a 30-bed unit with one RPN and one PSW, or a 12-bedded home with one person. You really need to look at how do you support safe practices and best practices with IPAC within their home. So it really pushed us to think differently of cohorting and donning and doffing, and what can be reused, and how do you deliver meals and meds. So I think the compatibility for the home to say, you're not a hospital, but you can still practice very safely, and we will support you doing that, as well as the rationale for why we were doing it, was a huge success and a huge support. And then communication, again, having the partners at the table, everybody sharing the same message at the same time, or not the same time, but putting it out at the same way, really showed collaboration. And I think that helped to build the trust across the homes. And I think it helped to build the trust working with the directors of care or the administrators, because they knew that it wasn't just St. Joe's saying this, it was public health saying the same thing. It was their long-term care Ministry of Health guidelines saying the same thing, and making sure that we were aligning to support, and it wasn't mixed messages. Because again, whether you're pre-outbreak, outbreak, or recovery, if you're getting multiple messages from multiple parties, and they don't always have the same support that we do in hospitals. So I think it was a huge success that we were all aligned, and just build that trust to support each other, and they know that they can reach out at any time. Lastly is just a picture collage of some of the places that we've been, to end on a nice note. Again, so we do have the Roslyn, which was a huge learning initially when COVID was in outbreak, and we did have to decant. But from there on, there was one other RCF that we decanted, but we have been able to manage these outbreaks in the community with all of the supports from primary care, the LIN, our hospital partners, which I think has been a huge success. Some may not think it's a success. It's a lot of hard work, but I think it is a huge success to say we can do this and we can work together to do this. The top picture, it's a little fuzzy, so I apologize. That's the St. Joe's team helping public health vaccinate all of the residents at Shalom. So that was a very, very exciting day for not only our staff to see the upswing after an outbreak. It was a pretty emotional day, going from initial onset of the outbreak and how bad it was, to COVID recovered and them getting their vaccines and sharing that success. At the table there, inputting her data is Joanne Jagger, the IPAC. And then we have putting on and putting off PPE. So Joanne and Ann Bielkowski here at St. Joe's actually put this process and steps together. We've shared that with public health, and they've taken it. They're definitely better with graphics than Joanne and Ann, but they've been able to put that together. So now we're sharing that with all of the homes. Jane Lunke here at Aberdeen Garden. And then this is just one of the RCFs that we work with. So again, knowing the population, they're not going to stop smoking. We have mental health and addiction problems. And so we need to work with the residents, and we need to appreciate that they're going to continue to go outside, even if they are COVID. But do we support smoke breaks? Do we support safe distancing when they are smoking? How do we work with them? This was not about changing and making our community partners like hospitals. This was about building and growing with them to support them the best that we could.